This episode is brought to you in part by the Doctoring Differently digital course. Are you a physician looking for more freedom and flexibility in your career? Have you wondered how physicians of all specialties can explore lucrative autonomous career opportunities like locums, expert witness, medical writing, consulting, and even aesthetics? Or maybe you've wondered how physicians can get their own health benefits, retirement plans, and malpractice insurance. Redefine what it means to be a successful physician in today's changing world. Learn it all in this one-of-a-kind, 10-hour on-demand digital course. Visit doctoringdifferently.com for the full syllabus and upcoming enrollment information. Welcome to the Doctoring Differently podcast. I'm Dr. Naomi Lawrence-Reid, a pediatrician, your host, and creator of the Doctoring Differently digital course that teaches physicians of all specialties how to find and explore flexible, lucrative careers beyond full-time clinical medicine. For more information, visit doctoringdifferently.com. Today on the podcast, I'm excited to welcome Dr. Maryal Concepcion, a family medicine physician and Filipinx creator who champions direct primary care as a viable and sustainable method of delivering quality patient care. She is a graduate of UC Davis and Creighton University, and she hosts the award-winning podcast, My DPC Story. I'm so excited to speak to Dr. Concepcion and all of the guests on the podcast. You won't want to miss any of them. Subscribe to the podcast on Spotify, Apple Podcasts, or wherever you get your podcasts. And subscribe to the Doctoring Differently YouTube channel to watch all of the episodes on YouTube. And now for my conversation with Dr. Maryal Concepcion. Welcome to the podcast, Dr. Concepcion. Happy to have you today.
Thank you so much, Dr. Naomi. It's fantastic to be here. We didn't really get to talk much when we were in person when I met you for the first time, other than you are like my twinning person in the Spanx world, super fashionable, but so fantastic to be here. Thank you for having me.
You're so welcome. Dr. Concepcion met in April of 2024 at the FlexMed Staff Conference in Las Vegas. I spoke about non-clinical careers for physicians. She spoke about DPC and direct primary care, which we will be talking about today. But you're right, we didn't really get a chance to sit down and connect, but now we have our chance. So let us start with your journey starting in medical school. You're a family medicine physician. So why did you choose family medicine?
Yeah, I love this question because I really didn't think about it until people were asking me, right? When I was in undergrad, I knew I wanted to do something health science related, but that didn't really solidify into family medicine until one, I did pediatrics and I saw that it wasn't really about the pediatric patients. You're taking care of a lot of anxious parents more so than the kids sometimes. And so I liked, yeah, you know a little bit about that world. So I really liked though, when I went into family medicine, one, because I had the opportunity to go to a rural location, I really liked family medicine manifesting in a doctor building a generational relationship with patients. And I saw that in small town Superior, Nebraska, where, you know, the doctor would be the person who delivered the mom's kid, and soon to be the mom's grandkid. And the same doctor would be the one to remove a mole, or the same person would be the one to, you know, put a cast on. And I loved that full scope aspect of medicine in general. And so for me, what spoke to me the most when I was applying to the match was family medicine, because I want to be a full scope doctor. And it was because I had mentors who were showing me that this is what family medicine could be, versus other family medicine experiences I had while in medical school, where it was like family medicine just sits and waits until the patients who the other specialties in the hospital don't have a person to take care of them, and then they're, you know, given to family medicine. Or in the clinic setting, where family medicine doctors were not happy for the most part. You know, they loved their patients. Very frequently, people in medicine love the time with the patients, but then once they step out of the room, that's where the problems start. The number of people who don't have an A1C of 7.1, or the number of people who you still have to chart on after hours. So those are the things that I saw in the more urban setting areas for sure, but also the places that were with opposed programs and the places where there was no option to see a private practice functioning. These were all systemic, I should say, like not systemic, but these were all system-based centers, like big corporation settings. Yeah.
Sure. So from there, it sounds like even going into residency, you had a great understanding, I think, of maybe the layout of healthcare and the realities of practicing medicine. So how was your residency experience in family medicine?
I had a great opportunity to go to an unopposed program. So in California at the time, there were only about, I think, 7 unopposed programs. And there was one that was closest to where I grew up in Sacramento. So I trained in
Quickly,
Modesto.
what does unopposed mean?
Yeah.
What does that mean?
That's a great question.
Unopposed.
And I appreciate that. It's all like when we talk medical leaves and our patients are like, wait, what does SOP mean? That's more of an entrepreneurial term. But when it comes to opposed versus unopposed, so opposed means a program that has residency specialties that go beyond a single residency. So you have family medicine, psychiatry, the 6 things that we do rotations in medical school. Sure. If a program has more than one of those, it's an opposed residency. If they're seeing the same patient for possibly, like if there's overlap in the ability to give care. And that's where I described like how internal medicine would get the really high acuity, interesting cases, Dr. House situations, and family medicine would get like, here's a person who needs hypertension medicine. Like, okay, I really learned a lot there. Versus unopposed, where we were the only residents in the hospital doing clinical medicine, inpatient peds, labor and delivery, surgery, ER, ICU, all of those things. We were not competing with other residents to have the same experiences. Yep.
I see. Thank you. I had never heard of that term. So I learned something new today. Thank you. So you picked an unopposed program because you wanted that full scope, full spectrum, it sounds like incredible training. Okay. How were those 3 years?
Yeah. So one was that it was an unopposed program. So that definitely set the bar higher in terms of making sure that I was trained and confident enough to be able to practice on day one out of residency. So I really appreciated that. I appreciated that my physicians who were my attendings were also full scope doctors. They did deliveries, they did procedures, they saw people in clinic, they went to the hospital. So I had amazing mentors in residency. When it came to the experience, Doctors Medical Center in Modesto is like where all of the rich people don't go. And so we see the people in greatest need, the people with the toughest pathologies, the people with the toughest socioeconomic barriers to healthcare or accessing prevention measures, right? So I thought it was really awesome that we got to participate in our community in a way that we were really, able to make crucial differences. I mean, you have people who they don't necessarily get as sick because they have access to care. They have the gas money to go drive to the doctor, right? So it was very much social justice fulfilling for me to be at that hospital in particular. Okay. And then in regards to the type of training that we had, it was very much first year you learn, second year you know some, and you're able to do some teaching, but you take on more responsibility because you know some more. And then third year for us, our final year in our training was you are the person leading the team. And so you were able to really teach, and you were able to really, the whole see one, do one, teach one. That's definitely how our residency was structured. And all throughout, and you're right, like I knew that what I wanted after residency was a full scope option to practice medicine. And so I did things like my third year, I did a colonoscopy, like I developed my own extracurricular, or not extracurricular, but like rotation, I guess, in residency. And I went out back to Superior and I did more colonoscopies. And so I was able to craft my own focus. I was the only person in my class to do a rural focused, full scope medicine focused track. And it was
you
great.
realized at that time you wanted to it sounds like your residency may have been somewhat rural, but you wanted to continue on that rural, full scope career path as an attending. So where did you go, and how did your first few years as an attending look like?
Yeah, so Modesto is very much like, it is an urban setting. It's not a city in terms of like Sacramento, San Francisco, but it has a decent population compared to where I live now, which is about a 4,000 population town. Wow. The pandemic shifted that a little bit because everybody bought all the cabins that had been for sale for decades. But the first couple of years were great in that we had my husband, who's also a family doctor, and we were able to, achieve what, number one, drove our selection of where we were going to practice. Even, I think, above rural medicine was the idea to do a job share. So a job share, for those people who are not aware, is where two doctors or more doctors can combine their hours together to make the equivalent of a full-time doctor. And so for my husband and I, we knew that we wanted to have a family at some point. We have a 3 and a 6-year-old now, but at the time we were preparing to choose a career that allowed us to be at home because sadly, and I don't know if some of your listeners have experienced this or they've heard these types of stories too, but like there was an OB-GYN down in Phoenix who was joking about like, I actually don't know how old my youngest is. I think 24, 26, something like that, but they're in Chicago and I work out here in Phoenix. And we heard these types of stories, or we heard the people who were like, well, I didn't have family because I worked like, 8 to 5, really longer after hours. And I just finally retired, and then they got cancer and died within like a year of retiring. And so we wanted to make sure that we were addressing that, work-life balance, to be able to be at home with our kids, know our kids' ages. And so we only looked for job share opportunities. That narrowed the pool down. And then also when we were like, okay, here's job share option. Now we want rural. And then we also wanted to be close to our parents. So those were our like 3 selection criteria. And our families are in California. And so the first 2 years, though, were great because we found a position. I am in Arnold, California, so you can Google that, like Arnold the Anteater, for those people old enough to remember that cartoon on PBS. But a town of 4,000 people, an hour and a half from the nearest Target, Costco. Airport is about 2 hours away. So, like, it's different growing up in Sacramento and training in cities. Like, to access services is different. But we were on a salary the first, like, I think 3 years. We were told, like, and that's what we call in the DPC world the golden handcuffs. Like, you get this amazing deal. Like, if you work at Kaiser, you get 7-year mortgage on your house, and you get all these fancy things. But then what happens after? We joke about Kaiser selling your soul to the devil because it's just untenable for a person like me who wants to deliver quality care by having the time and relationship with my patients. I could never do that in Kaiser. I would not be able to survive.
So you were job sharing. Were you job sharing with your husband at this point? Is this that first job where the two of you were sharing like a full panel together?
We only worked 2.5 days a piece. So I worked full day Monday, Tuesday, half day Wednesday, and then he picked up the rest of the week. So that's how we worked. Wow. We shared an office. We shared the same panel of patients. Although technically, even within the panel, people segmented themselves. They self-selected, like the husbands would see my husband, the wives would see me. But yeah, we were there doing the same job, and I did that job until I did DPC.
Great. I feel like I have to ask, I feel like that could make or break a marriage working so closely, but you still had, your time in the office, his time in the office. How did that go relationship wise? I apologize if I'm overstepping, but I'm very curious.
I've not heard of
that
not at
arrangement
all.
For physicians.
I think I appreciate that question rather than, taking a step back, in offense because of it or anything like that, because like, I am not the only person who's experienced a situation or who could potentially experience a situation. So happy to share. But I think, one, it was easier before kids. Like, it's definitely harder when you're like, okay, now we have to be a mom on top of all of this or a dad on top of all of this. But when we were at the office, even though we had the same panel of patients, we had the same front office, back office staff, it was, we ran our own practices. I mean, that's what I think is great about when we're doctors is like, you're practicing evidence-based medicine, keeping up to date on stuff. And so it's like how you handle your patients is no different than if we were in a resident clinic together, which we were at one point. It's like you see your patients, you do your charts, you do your orders, and I'm doing the same thing over here. So it wasn't a big stressor to be working together at the same job. Yeah.
Mm-hmm. Good. And to your point about the golden handcuffs and those types of institutions that dangle beautiful gold and riches in front of, generally young doctors, fresh graduates, straight out of residency, who are saddled with debt, who are in their probably early 30s, considering having a family, finally starting their lives. And yes, we are ripe for, picking a job with all of those real shiny things, and all of the promises that are made at the beginning, and then a few years in, realizing like, oh wow, I am paying for the riches. I'm paying for it now, and I don't know if I can continue on this path. It feels like there's no way out. It feels like I have no other options. But of course, we're here to talk about our other options. So what happened? You alluded to your DPC or direct primary care transition. So what did that look like?
Something unbelievable happened when, something that I had never seen in residency, heard of in residency or medical school, seen another attending go through. When the time of our golden handcuffs ended and we were in then contract negotiations to go to an RVU model, we fought left and right for various things like, how are you paying us $47 an RVU when that's not even fair market value for Western region MGMA data? Like, don't tell me that's not the right data, because I talked to all of these doctors in rural and urban, in Sacramento, Modesto, Santa Cruz, all of these places, who gave me their contracts and said, that's not the RVU amount that they're getting paid in a bigger city for doing less full scope care, right? And so they were like, oh, we didn't know. And then they raised the rate to $52 an RVU, which is just insane, because a nurse practitioner in our state, if you Google it, makes about $79 an hour, but we make $52 an RVU was at the max of what we were making in our fee-for-service position. And so it just became more, untenable things like, and this is important for people to hear, because especially if you're in a place where you're reading a contract, there are things that exist like evergreen contracts, and that was being proposed to us, where your rates will never be renegotiated. Things like,
oh wow,
yeah, things like exclusivity. So like during the pandemic, had we signed something like that, if we worked for Teladoc or something to make ends meet because we weren't able to see people in the clinic because the clinic was shut down and you couldn't make RVUs, they had exclusivity clauses. So like, if you work for another company, we own your money. And I'm like, just like anyone with common sense would be, but you didn't go to medical school. If I don't see the patients, you don't get paid. Admins who make a ton more money than I do. Like, this is ridiculous. They had clauses like, if we need you to practice in Los Angeles, we will move you. I'm like, no, that's not going to happen. Sorry, ain't going to happen. I'm not going to sign that. And then, they had magic math in terms of like, again, what the RVU would be based off of. And, they pulled quick things like CMS raised rates for primary care reimbursement, but then they said, yes, they have. And we're going to take an even bigger cut and then leave you with this amount, which happens to be less than what CMS was supposed to give you to start with. So just completely untenable situation. And it culminated in the back and forth was just too much for them. They went through a massive admin change and just said, and we have the letter, from the admin who claims that he cares about people. If you do not sign this contract, you will be terminated in 30 days. And so that was my Band-Aid ripped off to say, well, poop or get off the pot, So it was like, okay, I had known about DPC, had not planned on it because I was still on a salary. Like the motivation was not there to go from a place of, I only know how to be an employee to you're going to start being an entrepreneur. self-taught. Like, that's not an easy thing for people to do when, you know, you might be the only breadwinner in your family. You might be the highest earner in your family. You might be expecting a baby soon. Like, all of the changes, it is very challenging to think about the pivot. But this is where I encourage people to know that DPC is an option, because then you can at least go into the world with eyes wide open. It's just like how you do direct contracting with hospitals. I mean, like, people don't know that that's an option unless they hear your story, right? So that's the important thing to hear. Like, family medicine in particular in California, the data shows that 86 to 90% of family medicine residents are going into these fee-for-service employed, you know, huge behemoth corporation models. And they don't know what they don't know. So, like, if you go to the Kaiser Medical School, the only thing that you know is Kaiser medicine. You have to see 35 to 40 patients a day, period. Like, that's what your attendings do. You can too. And it's like, but why? So I really think that, you know, for me, I went into medicine, just as I'm sure you were, and I heard you say this at the FlexMed Summit, to take care of patients, but that's not what you're doing when you're going into fee-for-service. And for me, you know, the autonomy that comes from not doing that model, and in my world, that's direct primary care, allows me to do what I actually went to medical school to do, and my patients love it, and I love it.
You made many great points, but I'm going to pick the one about you reading your contract. And on this season of the Doctoring Differently podcast, we actually speak with a physician contract attorney who taught me things, opened my eyes, because of course we as trainees, medical students, residents, we never get access to physician contract attorneys. First of all, that is I think a very small subset of law. Don't worry, healthcare attorneys, a lot of those, but specifically physician contract attorneys, no. And as you said, you are handed a contract, we skim it maybe, we kind of look, maybe we take a screenshot of a piece and sell it to our, or send it to our uncle who's a real estate attorney to see if he can tell us what's going on. So we often do not have any real insight, and too many physicians also feel like they can't even oppose or negotiate that contract. And you made a great point of saying the RVE, there are so many things that you can negotiate, not just your salary, not just your vacation, but your non-solicitation clauses, your non-compete clauses, your RVUs, bonuses, and base salaries, and all of these things can be negotiated. And I particularly love your energy of, you can't do what I can do. You don't know what I know. I'm the prize here, and you're not meeting my terms. I'm sorry you had to find out in the ripping of a Band-Aid way, but you know, I think it's an important lesson for us all to know, or at some point learn, that we are not important to these institutions. We generate their profits, and they will restrict our salaries as much as possible to maximize their profits, which is not good for patients ultimately, and certainly not good for the physicians who care for them. Okay, thank you for saying all of that. Tell me how the DPC pivot happened.
Yeah, so I was at a point where I was 28 weeks pregnant with our second kid, and I got this letter that said, like, you are going to be fired if you don't sign our contract. And the 95% of me was that person who was standing up for herself to say, this is not okay. The 5% of me was the defeated, like, I can't win. I cannot win. I'm going to lose my health care. I'm not going to be able to see my OB. Like, all of the defeatist attitude was about only, thankfully, 5%. But I knew about DPC for about a year and a half, maybe 2 years prior. An orthopod in our area, ironically, was the one who said, you need to look up DPC, had no idea what it was. But this orthopod also left the hospital because things like, we only have this hip replacement, hardware for you to use. You don't have a choice. And she was like, no, thank you. I'm going to go elsewhere. For me, I knew I couldn't do this way of medicine anymore. I knew that I hated doing Medicare physicals. Like, for those people who've done Medicare physicals, it's insulting when I was spending 45 minutes to do a Medicare physical and the clinic down the road was having their nurse do all the questions over the phone, not even, because it's not a visit where you're supposed to touch or listen to a patient. So the nurse was doing it, the doctor was signing off, and they were getting all the Medicare dollars, but I'm like trying to do an actual quality visit, spending 45 minutes asking people if they wear their seatbelts and counseling them on this stuff, where it's like, this is not very stimulating for my brain, and nor does it make me want to continue doing this. Like when I'm asking questions that you technically could have a nurse ask or another clinical staff, but not yourself. It doesn't challenge me. It doesn't, make me want to know more things, learn more things. Anyway, so I knew that I could not do medicine the same way. And the only other option that I had heard of, because I didn't want to do concierge, well, I shouldn't say the only option, but I did not want to do concierge medicine because I am not in this to take care of rich people only. And I'm not in this, world of rural full scope family medicine to only cater to those people who have needs and to ignore the people who do not have the financial means to pay for the same quality of care that every single American deserves, in my opinion. And so DPC allowed me to deliver concierge level care for everyday Americans. So like the average over the nation is about $75 to $100 per member per month. And that's all ages all over the board. For me, I have people who they're uninsured Medi-Cal beneficiaries, and they tell me one visit to the ER can be $2,000. I know how that goes. I have insurance, and I paid $2,000 for a shot of Decadron when my kid was having a respiratory rate of 72 for too dang long, and I was worried he was going to crash. So I know how that goes. And so these people who understand DPC are everyday people. Most of my patients are blue collar people. They work hard. They take good care of their families. They try to do their best. And now they have, for less than one visit to the ER, the ability to pay a personal physician for a whole year of unlimited care. The poorest region of Georgia. People are financially poor. They might be uninsured. They might be, undocumented. We don't care. If you're a human being, we went to human being doctor school. We can take care of you.
We did.
Yeah.
We did. Okay. When we come back, more with Dr. Maryal Concepcion about the wonderful world of direct primary care practice. Today's episode is brought to you by Foster Crown, a boutique physician and executive search firm. Foster Crown facilitates both permanent and independent contractor placements nationwide, a first of its kind, specializing in physician representation. If you have interest in working locums but need assistance orchestrating the details and managing the contract, Foster Crown can assist. This includes contracts, negotiating compensation, malpractice insurance, credentialing, and invoicing. Let Foster Crown handle the particulars so you can focus on patient care without the burden of administrative tasks. Visit fostercrown.com today to discuss your career goals and how they can help you achieve them. Okay, we're back with Dr. Maryal Concepcion as she has left a full-time clinical position and is now starting her direct primary care practice in Central California. So how did you do that? How did you hang the shingle? How did you start DPC?
So I will say I had sort of a cheat sheet because I started my podcast, My DPC Story, where I'm interviewing doctors to ask these same questions about, how did you get started into DPC? Specifically, how did you open? How are you managing the workflows, the finances? How did you prepare? All of these things. And I had a little bit of a crib sheet because I was talking with other doctors. And that really helped me know what I needed to know to open. Specifically, I knew that I needed like EMR technology that worked now, not that like is going to work in 5 years as we get customer feedback, but I knew I needed, technology to work with me now. I needed technology that was going to be accessible for my brain and the way I need workflows to go, but also for my patients. Specifically, I needed a patient portal. Like that's how detailed I knew I needed to have my practice be. And I knew I needed to make it such that my husband would be able to join later on, which he did because, side note, he was role was eliminated at the clinic that we were working at because the clinic went to a non-physician model. That is another thing that can easily happen, because when you said they don't care about us, they do not care about us. And
just to clarify that probably, just for our listeners, I suspect you mean nurse practitioners, physician assistants. We're seeing the patients, which means they could pay them less. And again, this clinic could pay those providers less than they would pay a physician. Again, maximizing their profits, their corporate profits, and eliminating the quote unquote need for a physician, because a nurse practitioner or physician assistant could, in their minds, or presumably provide the absolute same level of service and care.
Yeah.
Okay, please continue. Just wanted to make that point.
Yeah, it is a very ugly truth in California that I experienced just living in the state, and with the law changing just January of 2023, such that a nurse practitioner can work without physician oversight with 4,600 hours of supervised care. That is for people to calculate about the equivalent of the first 2 years of medical school before we even start clinicals. And you can get an online nurse practitioner degree. I have tried. You cannot get an accredited MD or DO. So we can't go to online school, but they can. And so when you show up into the clinic, at the clinic that we worked at, you do not even have the option to see a physician. So that's what kills me about rural America, especially when it's like, my husband wasn't looking to leave because he stayed on. This answers the question about how I transitioned. We planned so that he would stay on, sign the contract, and I would do DPC so that we would at least have some kind of steady income. But other than that, I don't have an MBA. I challenge people who think they have to have an MBA to be an entrepreneur.
Yes.
Because we went to doctor school. Like, not a lot of people can have the smarts to go to doctor school. So if you can learn how to take care of a human being and all the systems, or if you don't know, you know where to look it up. The same thing with, all of this business stuff. So basic things like, what's a business plan, a P&L, profit and loss statement. There are free resources like the Small Business Administration. So score.org, SCORE.org is a great resource to literally, like, how do you start a business? This is where, when it comes to physician contract attorneys, one, healthcare law is an optional, like, it's an elective. So healthcare law isn't even part of law school's curriculum. Yeah, it's crazy. And then also, when you are working in direct primary care, all of the things that we do entrepreneurial are very much attended to by small business attorneys. So when you're not contracting with the big behemoths, that's something important to know, because you can look for a non-healthcare attorney who will still understand like how to hire employees, how to, protect your practice in terms of this or that. But we're a small business. Tattoo parlors are also small business, right? So it's like small business attorneys are a very important thing to keep in mind. Anyways,
resource.
DPC, yes. Yeah. But DPC for me was, I know how to do the medicine, but how do I streamline this medicine to make it the way that I would optimize my medicine, because I have the time to do it. So it allowed me to think about, what's my ideal practice? Who's my ideal patient? How much time would I estimate I would spend with these patients? And then those questions were answered financial planning wise. We had my husband working the fee-for-service job, and he was on RVUs, but at least it was regular income. The way that I opened was very much, I was very grateful because I had been known in the community. And so probably 80% of my patients who joined me within the first 2 months were my patients from my previous practice, and they all have insurance.
Interesting.
But you can't get
access. So you didn't need to have a non-solicitation? You didn't need to have that, was that non-solicitation clause not in your contract, or how did that go, now that we're talking about contract medicine? So
I love this question. And this is coming at a time when the FTC has just technically banned non-competes. Yes, there's an exception for nonprofits. Like Emory is a nonprofit, which kills me. But so are other companies that are making profits. But when it comes to California, non-competes have always been non-enforceable for my medical career.
That is correct.
Yes.
Yes.
So that was a huge win. Oh, people will still try, right? And that's again,
they
knowledge
will.
is power. Because if you don't know that it's not enforceable, you could waste thousands of dollars on an attorney to combat something when it's like, but you literally could open literally next door or across the street, which is pretty much what we did.
That's right. So I know that that non-solicitation clause, or that specifically, if you are listening and you are a physician in the state of California and are, your mind is turning, you're hearing about the FTC, you're wondering if your non-compete holds up. Your non-compete has never held up, not in any recent years. The Attorney General, his name is Bob Bonta, he releases a statement every 8 to 12 months saying that non-competes are not enforceable in the state of California. Actually, to protect a lot of low income and migrant workers. Ironically, it protects us doctors as well. I'm not sure if he knows how it can actually truly benefit us. But as you said, it does not stop these hospitals from trying, from putting it into our contracts, knowing that we don't know our rights as employees. We're obedient. We don't want to get in trouble. We don't want to get a stern message from a lawyer or an email from our administrator saying that we've broken rules. So we often don't even try or consider doing other things. So I love that you knew your rights, you knew what state we were in and what you could do with your hard-earned degree that is yours and yours alone.
And I will put an amazing resource here, especially for legal advice per state.
Please.
There is a doctor, Dr. Phil Eskew, who is an amazing, kind genius, who is a JD, MBA, accounting undergrad major, and a DO. So he is all of the things, and he has put together this thing called the DPC Frontier. So it's dpcfrontier.org. And that is a place where you can go to look up your state and look up what is the status of direct primary care law in your state. In California, we do not have a DPC protective piece of legislation as of today. That is not something that we hope will continue in the future.
Today is Thursday, June for our listeners. Today is Thursday, June 6th, 2024. Game 1 of the Celtics winning the NBA Finals. Thank you. Please continue.
Love it. So yeah, you don't know what you don't know. And so educating yourself is a very important thing. Just like we did prepare for, renal or pulm or whatever we were doing in med school. The same thing applies again, because we're smart people when you're doing DPC.
Right.
Like there are so many resources. On my podcast alone, there's over 165 doctors sharing their stories of how they opened. And on the Frontier, there's, summaries on legal updates on every state. There's so many resources out there that are so helpful. So starting DPC is not as anxiety riddening as it used to be, because, and I'll just put out numbers, like 2014, 2017, somewhere around there were like 147 practices. I think that was this is from my recollection. And then by, a few years later, we had hundreds, and now we're in the thousands. And so you see direct primary care as a business model. For those listeners who are not primary care doctors, we have people who are using DPC, the business model, as dermatologists, pulmonologists, surgeons, rheumatologists. I mean, the list just keeps going on, because we know that when you put an insurance company between you and the patient, the cost of care goes up, the accessibility goes down.
What would you say to a physician who thinks they need an MBA to start a DPC practice, or really any independent venture outside of full-time clinical medicine?
It is not a surprising question, because especially when you are a physician, possibly a type A personality, possibly an overthinker of many things, so it's like you want to be prepared. What I would do first is, before, go crazy and investing in, the thousands of dollars for an MBA, even an online one. What I would do is look up resources first, listen to podcasts, read books, do your due diligence to literally find, there's like free checklists. One of them is on my resource page. It was put out by a company called Bagel. It's literally, it's like, this is what you do to market your practice. This is what you do to choose an EMR. These are the conferences to go to. So it's like, I didn't have that for renal. Like, nobody told me, like, these are the things you need to know to be able to take care of a patient between normal and dialysis. So it is so amazing how direct primary care is really how do you, the doctor, wish to take care of your patient? Let's do that. Like, that is what I would say breaks down that it not that it breaks down, but it allows for that mind shift to happen, because you're no longer tied to, but the insurance won't cover that MRI. I suspect that you have, avascular necrosis in your bilateral hips, but we need to get you to PT for 6 weeks. And then if they don't cover that, then we need to get you other things before we will get you your MRI. And now it's like, you have the ability to, if you're driven by how do I wish to take care of my patients, and that's what drives my practice and how I grow it, you have your thoughts change. Like, how much does a CBC actually cost? Oh my God, it's under $6. How much does an MRI cost? Oh my God, it's under $500. Like, you literally start looking for other ways to get your patients accessible care, and it's not breaking the bank. So literally, that's what I would say to people, like the overthinkers of us, the type A, like, I'm totally raising my hand on both of those. Yeah, okay, yes, you say all of your things, but then also just write down in front of you, if you're a visual person, or listen to it, whatever you have to. I am a physician, and the way I love taking care of my patients is, that's your DPC. It's as simple as that.
That's your model. That's your model. And what you've exemplified perfectly is the community of doctors who are sharing knowledge, who are sharing resources, who have found their own autonomous happiness in their career, able to practice medicine again the way they want to, deliver excellent care to their patients, and are not keeping it to themselves. You've shared about 5 very, very fruitful resources just here now. And that has been my experience in almost all aspects of doctoring differently, has been I found a physician who was doing one thing, and they shared their knowledge, they shared their resources. And I love that about us. And I love that you've shared those. So these are nice, I don't want to say NBA alternatives. Yeah. Or I do want to say MBA alternatives, because we really, degrees are our currency, right? Yeah. We don't think that we can do something until we have gone to school, taken a test, put on a cap and gown, gotten a diploma or certificate, and now can put more letters behind our name. Yeah. That is the permission to do a thing, which really, that mindset can shift after you've gotten your MD. Yes, you need permission and all of the training to do clinical medicine, but everything else, most business owners in the United States have high school diplomas, and that's it. And yet we, with all of the training, with all of the intellect, think that we can't do it. And so thank you for helping to change that narrative.
Absolutely. And it breaks my heart, because with that, unfortunately, I see comes the lack of knowing one's own value. Like how you said that, we have all of this training. We are freaking smart people. Like, we don't even know how smart we are, because like we hang out with each other, and then we're like, how do you not know that, whatever thing we learned about in med school? Like, of course that's common sense. It's like, this is why we have to explain medicalese, because we are in a different, because of being doctors, we are in a different subset of the population. That doesn't make us better or worse than anybody else, but we're just trained differently. We speak differently. Yeah. And so when you're able to be an entrepreneur, that's one of the things that I love about DPC is, one, I feel way healed faster than I ever would have been just like not doing medicine. Because I know that when I see, a Stripe payment or whatever, it's like a patient believes in what I'm doing. A patient has told another patient that they love what we're doing, so another patient has joined my practice. Word of mouth, as the way that DPC grows, it's super common, but it also just really heals the person who has been devalued and who doesn't even know their financial worth per hour when we go into fee-for-service, and we are just like, I got my check today. It's enough to pay my bills. I'm going to go to Disneyland, but I don't know how much I'm worth per hour.
That's right. Intentionally, we come out of our training, and these jobs never want us to know the true value ever. We don't ever even accept the co-payment, right? So we have no concept of that. My time, my energy, my education, my experience is worth this. And I think that's, of course, very much by design, because all of those extra profit dollars funnel elsewhere, far from us, and far away from the patients who actually are likely vastly overpaying for their healthcare in the conventional fee-for-service model. So thank you, Dr. Concepcion. I have one closing question for you. And that question is, did this vibrant DPC version of your career happen on its own? Did it fall into your lap, or did you take some action in order to make it happen?
So it's not a clear answer, because one, I will say that fee-for-service was threatening to put a damper on my light, on my candle, flame, whatever you want to call it. And I reacted to that. I fought to not have fee-for-service take my energy and my enthusiasm about family medicine.
You had a boundary.
Yes. Yeah. And I think that portion is the part that I had to work to remind myself and respect and listen to when I chose to do this way of medicine. In terms of, the working for it, just a note about an MBA. I could have done an MBA, but I wouldn't have had the clinical experience, the clinical and entrepreneurial experience to understand what the MBA would have been talking about theoretically. So I think that it is definitely not something that has fallen on my plate because of the fact that I have to learn about business. I have to change my business. I mean, I work on the business rather than in the business as much as I can right now, because it's in the first 3 years of my practice. But it also did fall into my lap because I am very grateful for people like Dr. Garrison Bliss, who is credited as the founder of this entire movement. He shared, his founding story on the podcast. So if you Google Dr. Garrison Bliss, My DPC Story, you'll find it. But it's incredible. And I'm so grateful that other physicians have gone before me to build out a way of saving careers and saving accessibility for patients, whether you be urban or rural. And so in that part, it did fall into my lap because it fits so perfectly with my desire to deliver care. But it is definitely not something that is easy. There are some days where I work harder than fee-for-service, but the work is different. The work is stimulating. The work is challenging. The work is a million times more rewarding than I ever had in fee-for-service. And I know how much my worth is per hour. And I know, what, that no is a sentence, period. That is not something that has to go with no but, no explanation. No, it's just N-O, period. That is a sentence.
Right.
I didn't know that in fee-for-service. So
no, it's not. Yeah. Your no means very little. That's right. Your no is not yours to have. So Yeah. Okay, great. Well, thank you again for coming on the podcast. Please tell listeners where they can find you, your platform, your podcast. Give us the names.
Yeah, sure. So My DPC Story, for DPC for direct primary care, mydpcstory.com is where the podcast lives on the internet, but it's on all major podcast platforms. And then in terms of there, you can find contact information for all the DPC doctors who are featured, resources, conferences that you can go to. I will say that a DPC conference is like, one of those, it's one of those conferences where you're like, did we share Kool-Aid here? Because you all are happy and this is weird, because you don't go to a physician conference where everyone is like, my life has changed. It's amazing. But conferences, you can find other resources like, videos and podcasts and whatnot. So that's definitely my main page, and on all socials, I'm just at my DPC Story.
Great. Well, I know some listeners will be finding you. I have fielded questions about DPC, myself not being an expert at it, but I am so glad to have you as a resource to point people to. So thank you for coming on the podcast, Dr. Concepcion.
Awesome. Thank you so much. This has been awesome to talk with you.